Very pleased to have with us our speaker for today, Dr. Lisa Del Giudice. And so Dr. Lisa is the Regional Primary Care Lead for the Toronto Central Regional Cancer Program North. In this role, she is involved in developing and disseminating guidelines for providers and developing programs that will improve patient care throughout the cancer journey. She's also the assistant professor in the Department of Family and Community Medicine at the University of Toronto and at Sunnybrook Health Sciences Centre. She also has clinical experience providing routine primary care as a family physician. So I will pass it over to you, Dr. Lisa, for our talk today.
Thank you. Thanks for inviting me today, and the Wellspring Group, and Vanitha for inviting me. Someone had just put up their hand, and I don't know if it was technical issues or something like that. So before I get started, I thought I would just address that right off the bat if there's something that needs.
Oh, so I think the raise hand icon, sometimes it's just hit by accident, but if there are any questions or anything that you'd like to let us know, if people could use the Q&A icon or the chat to let us know, that would be awesome. Thank you.
Thanks. Yeah, I just want to make sure before we got started, if anybody was having technical difficulties, we address that right now. Again, thank you for inviting me to come to speak about this. This is something that I am very passionate about, and I'm happy to come and do this. So I'm really excited that you did invite me. And my talk today is about transitioning your cancer care beyond the diagnosis and treatment phase of the journey. And so what I'm going to be talking about a lot today is what we call well follow-up care. That's what we call it sort of in medical terms, and what we know sort of internationally of what do we call what used to be called survivorship care is now called well follow-up care, and it changes all the time. So this, you could also call this well survivorship care as well, in addition to well follow-up care. But basically what we're doing is we're focusing on the health and life of a person with a history of cancer beyond the acute diagnosis and treatment phase. And there's many components to this that we're going to talk about in turn later on in more detail, but this includes managing precancer and new comorbidities, including side effects of the cancer treatments, cancer surveillance for local recurrence and metastases, monitoring and management of late effects, and then prevention, screening, and health promotion. We'll talk about these in detail a little bit later. So the big question is, when does well follow-up care start, or when does survivorship care start? And often people wonder, like, how long after they complete active treatment? As far as I'm concerned, some of the components actually start during treatment, and that's especially the health promotion and prevention and screening, which can happen during your treatment. But some of it also happens, can really happen day one, pretty much the day after you finish your chemotherapy and your or your radiation therapy or surgery or what have you, whatever comes last. And the question also is, when do you no longer need to see your oncologist for well followed care? And that really depends upon the individual person. So sometimes, and the cancer that they had, and the experiences that they've had. So it varies from person to person, and who actually does which components also can vary at the timing that it starts. So there's really no definitive answer to that. But it does vary across the country in terms of when people are actually discharged from their family from the cancer center. So where and with who should the follow-up care take place? And so there's been a huge amount of debate about this, and this debate has been going on since the late 90s, early 2000s, and there was a document written in 2005 to really help decide this, as a lot of studies were emerging at that time in terms of where is it best to do the well follow-up care. Should it be done in the cancer center, and it should be done in the cancer center by your oncologist? Should it be done by a GP oncologist, so you transition your care within the cancer center to a GP oncologist, or to a nurse practitioner who's specialized in survivorship or well follow-up care? The other debate to this is, should patients go back to their primary care provider? And that could either be their, what we call a family physician or a general practitioner. And in many cases in Ontario and across Canada, that may also be a nurse practitioner as well. And so there's been a lot of research done on this, as I mentioned, and a lot of the research has actually shown that it really doesn't matter where you do your well follow-up care. And in some regards, and I'll talk about this a little bit later, that they actually found that the well follow-up care, if you look at this slide that we talked about, a lot of that family doctors are already doing, or their primary care providers, their GP or their nurse practitioner is already doing that managing of precancer ailments, that monitoring and management of late effects, that some of those diseases that can occur that would have happened anyways, and also are doing a lot of that prevention, screening, and health promotion. So you may have noticed, and some of you may be in that position right now, where you've been discharged from the cancer center to your primary care provider. You haven't, and you're at a different stage and you're still in that active treatment, but you heard about it, or you're sort of just finished your active treatment. There is a lot of fear about well followed care from primary care providers, and that's where the majority of well followed care, like I said, has been happening. And that's very common to have some concerns and some fears about it. In some cases, some patients haven't seen their family doctors in years, so they feel a bit odd going back there, thinking they don't really know what's happened all along. In some cases, on the good side, the primary care provider might have been the person who actually diagnosed the cancer, or sent them for a test or to a specialist because they were suspicious of a cancer. And in some cases, there may be some resentment because the primary care provider didn't pick up on the clues early enough, or not at all, and they were diagnosed in the emergency department, or diagnosed some way other that has led to someone not feeling great about going back to the primary care provider, and that's understandable. So I did ask one of my patients who was going to be discharged from the cancer center, and asked her and said, like, what are your concerns and fears? Like, I've got to put together this talk. I've got to talk about this, and tell me some things that I can better understand how a patient feels when they're being discharged from the cancer center. And so these were some of the things that she said. She said, the complete lack of security when leaving the center. All of a sudden, rather than being at the center daily where people know you, where you know what to expect, where there's that feeling that if something goes wrong, someone will catch it, now you're more or less on your own. And she went on to say, I think we're all concerned about how to make the transition back to a GP's care as smooth as possible. We want to think that we're being listened to. We want to know that if a problem comes up related to cancer, we'll be quickly seen again. So those were some quotes from a patient of mine who was in a similar situation. So often a question that comes up is my primary care provider even qualified to manage my care? And as I mentioned earlier, studies show no difference in outcomes. And they actually showed some benefits with care being received from the family doctor exclusively by their family doctors. And so that is something that actually there's evidence to support it. And there's more and more that emerges from the literature that supports that evidence. As primary care providers, we receive notes throughout the cancer treatment, throughout the diagnosis and treatment phase, and as well at discharge as well. There are a lot of continuing medical education courses that are offered to primary care providers at primary care conferences, and in terms of webinars such as this for family doctors. Some people worry, is my family doctor too young to be able to manage my care and know about the intricacies? And I often say, well, the young doctors actually rotate through the cancer centers. They rotate through the specialty disciplines and learn about the latest new technology and the new treatments. And then some people worried, is my family doctor too old and doesn't really keep up with the literature, and doesn't really know what's going on, since they're at that point where they're just about to retire. And I often think, these old guys have a lot of wisdom under their belts from having had the experience with their own patients, to be able to know what to pick up on in terms of their own experiences from either having not picked up something soon enough and felt really, really bad about it, and it stuck with them for their entire careers, or alternatively, they've just seen this before and just know that might not be in the textbook, but they know they've seen it before, where that has led to a diagnosis and led to the cancer being picked up early. Also, people worry about that if they have an uncommon or rare cancer, that the family doctor may not know how to follow this up, or the primary care provider won't know how to follow it up. But usually when we've had these rare cases, I know from my own experiences, I'm usually on high alert. I'm really curious. I read up more on these cancers than I probably do on the usual ones that I see all the time, just because they are so rare and they're so uncommon, and there's that curiosity aspect to want to look it up. So is my primary care provider willing to do my well follow-up care? And this is one of the areas that I actually did a lot of work in back in the mid to late 2000s, where I published a paper that looked at primary care doctors, so family doctors and general practitioners across Canada, where we did a survey and we asked them, are you willing to do this well follow-up care? You know, the cancer centers are all prepared to discharge patients back to their family doctors. Do you want to do this? Are you willing to do this? And do you feel like you have the expertise? And we had a resounding yes, we want to do this. And in fact, what we found was that for those of you who are tuning in from out west, from the western part of Canada, was that those doctors, actually, it is part of their policy. They actually discharge their patients out soon after their active treatment is completed. So within the first year after active treatment, this was back in 2007, that they were already discharging patients back out. In Ontario, it was a little different. It was very hit or miss in terms of the policies here in Ontario, in terms of when cancer centers discharge out patients. Some are soon after, some are years later, some are, you know, basically until the oncologist either dies or retires, versus some other ones, some of the younger ones who were discharging out within the first year, and some within 5 years, some within 10 years. Basically, they were just waiting till they felt that the patient was ready to be discharged out. And then what we found in the maritime provinces was that they were less inclined to take on that care. But what ended up happening was that they actually implemented a lot of programs in the late 2000, early 2010s, where they actually said, you know, this is now policy, you're just going to have to do it. And they were more than willing to do it at that time. So some people worry about, does my family doctor even have the time to manage my care? They seem so busy. It's such a zoo. Every time I call, I have to wait on the line. When I get there, there's lots of people in the waiting room, or, you know, now with Zoom, most of you guys are having virtual appointments. You know, it takes me, you know, it's harder to get in or what have you. And what I usually suggest to everybody, and I say this to anybody, this is even patients who don't have cancer, is to make 3 or more appointments. And my suggestion would be to make an appointment to discuss just your cancer, about managing the side effects, about going through your concerns or fears or what have you. A second visit to talk about prevention, screening, and health promotion, which we're going to talk about a little bit later. And a third visit or fourth visit to talk about 1 or 2 medical issues per visit. I find that a lot of patients, regardless of what their underlying medical illness is, they want to bring in 10 or 15 problems for their 15-minute appointment. And what ends up happening is that we end up spending 90 seconds per concern. And I can tell you, even the best family doctor or GP cannot manage a symptom or a complaint in 90 seconds. It's almost impossible to do, and it doesn't help anybody by bringing in all these issues all at once. It saves you a lot of time, but it actually doesn't provide you with good care. Good care, you need to spend a good 10, 15 minutes on a problem or an issue, even if it seems small, to really make sure that you address it properly. If you're still not convinced and you want to change your primary care provider, and I apologize to those people outside of Ontario, but in Ontario we have a program called Healthcare Connect. It's managed through the what previously used to be called Home Care, then was called LHIN, and is now called Home Care and CCAC, the Community Care Access Center. Basically, you can go online and obtain that website there. There's also a phone number that you can call. And once you're registered with Healthcare Connect, you're assigned to a care connector. And these are nurses or navigators who are employed by Home Care, who will try and set you up with a doctor who is accepting patients and try to match you up best in terms of your living arrangements or where you work. Was a little bit on hold last year. A lot of family doctors and general practitioners were not taking on new patients because of COVID. They were barely being able to manage their own patients, let alone taking new patients. But a lot of those doctors have now started taking their new patients on. And so this, I know there's a big wait list now with Healthcare Connect, but hopefully you'll be connected up sooner than later. So I'm going to dive into well follow-up care and talk about each of those components that we talked about. So I'm going to start with managing the pre-cancer and new comorbidities, including side effects of cancer treatments. And so basically what this is managing some of those common ailments, such as osteoarthritis, diabetes, heart disease, and back pain. Those are the things that people might have had before they were even diagnosed, or started to develop them during their treatment, or even after they've had their treatments. And usually this is about managing the symptoms, the ailments, or the side effects of the treatments. And like I said, some of these might have developed before, some of these might have developed as a result of cancer, and some of it was going to develop anyways and has now developed sooner than it should have been. So I'm going to talk about some of the side effects of cancer and its treatments, and I'm really just going to focus on the next slides on the first 5 in terms of fatigue, pain, cognitive issues, sexual dysfunction and intimacy, fertility issues. I'm going to leave the bowel and bladder because they're very cancer specific, the lymphedema as well, that's cancer specific, the mobility issues and the stress and depression, which I believe you've had some other sessions on as well. So fatigue is the most common symptom that we see in patients who've had cancer or are undergoing cancer treatments. And for many patients, the energy never goes back to the way they felt before they had their cancer diagnosed and treated. But we know that research shows, and you're going to hear this as a common theme, is that exercise is the best way to improve your energy and to make your fatigue feel better. And what our recommendations are, aim to get about 30 minutes of moderate exercise on most days, or about 150 minutes per week. Choose something fun, something you like to do. Going for walks. It doesn't have to be taking up a gym membership. It doesn't have to be, long distance running or long distance cycling. Start slow, slowly increase the difficulty, and mix in aerobics and strengthening. And I'll talk a little bit more about this when we talk about exercise a little bit later. Two of the things that I refer to a lot, and I really like their resources, and is these two websites. One is that the health.sunnybrook.ca cancer fatigue. So that's available on the Sunnybrook Hospital website. And the other one that I really like is Mike Evans' videos on cancer fatigue. He did a fabulous video about 10 years ago, so it's been around for a while. And this is through the Reframe Health Lab. And Mike Evans has a whole bunch of other videos, and while you're there, you might want to watch as well, that are very interesting and very well done. So then the other next topic I want to talk about, another very common symptom, is pain. And there are really 3 types of pain. There's the acute pain that you feel, when you hit your hand with a hammer, or right after surgery or during active treatment. So that's that acute pain. There's chronic pain, which is either pre-existing. So if you had a bad back or a bad knee that you even had even prior to having treatment, or now is due to treatment. So some people end up with chronic pain because of the treatment that they're undergoing. There's neuropathic pain, and that's the nerve pain from cutting through nerves or damage to nerves from chemotherapy or radiation. So some of you may have had chemotherapy that causes neuropathies, that numbness, tingling, burning pain in the fingers and toes and feet. And what you might have noticed is that when you've maybe read about or heard about or managed or helped manage somebody's pain 20 years ago, is that they were given a lot of opiates. They were given a lot of morphine. And this is not about end of life. This is actually cancer patients who were treated with a lot of opiates like morphine or oxycodone or Percocets or codeine and what have you. And you might notice that there's been a big movement away from it. You might have noticed that, geez, I remember when my friend or my mom or my dad was undergoing treatment, they were given all this morphine and given all this Percocets. They were kept on for years and years and years. And you'll see now, for many reasons, that we don't do that quite as much anymore, and that they limited the amount of opiates, which is actually in the long run to minimize that chronic pain. Next thing I'm going to talk about is that cognitive or memory issues, or that chemo or fog brain. And research shows that about 2/3 of patients will experience this chemo or fog brain during chemotherapy. And many will continue to have it for 6 months after completing chemo. So if you're at that stage right now, it will eventually go away, and it usually fully resolves by 4 years. So if you're in that phase right now and you're feeling it right now, please know that it will most likely go away. Also know that it's not a progressive condition. And it does not increase your risk of Alzheimer's disease. So it's not going to get worse over time. It's going to get better over time. And it doesn't put you at risk for developing Alzheimer's disease. And we've studied this for many, many years, and we know that that there's a lot of evidence to support this. Unlike Alzheimer's disease, memory cues do help. They're what we call cognitive training. And also what also helps is rest and exercise. So there's that exercise theme again in terms of how to help with things. Sexual and intimacy issues are very common, especially in those people who've had chemotherapy or have had radiation to their pelvic organs. And this is because chemotherapy and radiation to the pelvic organs can reduce hormones, the hormones that are associated with sexual intimacy, so the estrogen, progesterone, and testosterone, which can also reduce libido. There's also body image issues as well. So people who've had, mastectomies or lumpectomies or significant scarring from their surgery, or have a colostomy bag or a leg bag for their urine. So you can imagine how that can affect sexuality and intimacy. It's a common symptom. Most patients are afraid to bring it up. As primary care providers and as oncologists, we're actually fully aware of this, and we're actually know how to deal with this. So please bring it up if you are suffering from this, to bring it up with your providers. There are things that we can do for vaginal dryness or vaginitis, that's pain in the vaginal area, through vaginal dilators, also known as biofeedback, or medications that we can use orally or topically to address those issues. And for men, obviously we have for erectile dysfunction, Viagra and Cialis, which is safe to use in patients who've had a history of cancer. Fertility issues are also common and this is often age dependent for women. It's often transient, the infertility issues, usually under the age of 40. Over the age of 40, it can become more problematic and difficult to conceive. In many cases, people do discuss their fertility before, and sometimes they'll have eggs frozen or embryos frozen before their treatment, or sperm frozen before treatment, in order to mitigate this in the future. And we know that pelvic radiation and chemo can affect fertility, just as it can affect sexuality and intimacy issues. So I'm going to move on to the next component of well follow-up care, which is cancer surveillance. And cancer surveillance is monitoring for cancer coming back. That's sort of what we're doing, and it's otherwise known as recurrence, and that's either locally, so where it originally was, or spread to other parts of the body, also known as metastases. And cancer surveillance is done through a variety of measures. This may be through specific tests, such as blood work or mammograms or ultrasounds or scopes, so colonoscopies, gastroscopies, nasopharyngoscope, or cystoscopies or what have you. So sometimes they're done through that mechanism. We usually know what to do. So patients are often told when they're being discharged from the cancer center, or when they're talking about their well follow-up care, as well as their primary care providers in the discharge note, are usually advised what to do and what to look for. And what I usually suggest, that if you have been discharged back to your primary care provider, is that you set up an annual visit once a year to go back to your family doctor to discuss about ordering these tests accordingly, or what needs to be surveillance, even if those tests are an examination, so like a breast exam or a rectal exam, or whatever it may be that may be required. So I usually suggest following up once a year, and make sure that you only discuss that, so that you don't get distracted by some of the other things that might come up. So next thing I'm going to talk about is monitoring and managing of late effects. And so we know that there are late treatment effects of chemotherapy and radiation, and some of these may not happen immediately. They may not happen in the first 5 years. They may not happen in the first 10 years. They may actually happen in 20, 25 years after treatment. And so some of these things may be the development of second malignancies. So sometimes, for example, we'll see people who have radiation to the chest for a lymphoma, and they have this at a young age, and they end up getting breast cancer or thyroid cancer later on in the future. Heart disease is another common one, again, where there's radiation to the chest, especially the left side of the chest, so for example, for left breast cancer, or also certain chemotherapy drugs that they end up developing heart disease 20, 30 years down the road, or even 15, 20 years down the road. Lung toxicity is another common one, usually associated with, again, radiation and or with some chemotherapy agents. Thyroid dysfunction is another one that we commonly see come up, especially where there's been radiation to the lung fields. Premature osteoporosis, very common as well. This may be associated with a reduction in certain hormones, so testosterone, estrogens, and progesterones, that are a result of either the treatments or as a result of radiation as well. Also seen a lot in patients who had long-term steroid use. Similarly, with early cataracts, that's often associated with people who had long-term steroid use as part of their chemotherapy regimen that can go on to develop early cataracts. So getting an eye exam is really important. In terms of reducing some of the effects, we do know that there's been a lot of efforts to reduce treatment. So the actual chemotherapy dosages and the radiation dosages and radiation field, so the size of the field of radiation, we've reduced a lot in the last 20 to 30 years, and that is to minimize some of the long-term effects of these treatments. And like I said, complications can take decades to manifest. And so you need to be vigilant, and you need to maintain a healthy lifestyle to minimize those long-term effects. And so we'll talk a little bit about diet and exercise later on in that regard. So what should you look for? So some of the things that you should be looking for, obviously, are new lump or growth, and that's anywhere. Changes in the area of your body where you had the cancer before. New pain that won't go away. Cough that won't go away. Persistent fatigue, unexplained weight loss or loss of appetite, numbness in the arms, hands, legs, or feet, new swelling of the arm or leg on the same side as the cancer, so that lymphedema. And if you experience any of these symptoms, you need to contact your family practitioner. And these symptoms don't always mean that your cancer is back. So you should bring them up to your primary care provider. You should look into it, or your oncologist if you're still being followed by your oncologist. But that doesn't necessarily mean, oh no, cancer is back. I've got a few more things to watch for on the next page. So pain that wakes you up out of your sleep, new headaches, especially if it wakes you up out of your sleep, visual changes. And that could just be due to old age. So again, that might not be a symptom that your cancer coming back. That might just be that your eyes are changing. Seizures, any new seizures should be brought up to your provider's attention. Blood or bleeding that you cannot explain. So if you cough up blood, you vomit up blood, you see blood in your stools, or you have some vaginal bleeding that you're not expecting, that should be brought up to your primary care provider or your oncologist or whoever is following you for your well follow-up care. Unexplained changes in your breathing or endurance. So usually my marker for this is often people have stairs in their home where they go up a set of stairs that they go up, or a hill that they go up all often, that if you have trouble going up those stairs or up that hill because it's hard to breathe or because you just don't have the energy to do that, that's something that needs to be brought up to your provider's attention. And then finally, any jaundice or yellowing of the skin and eyes. And so those are some of the common things that we get people to look for. So I'm going to move on to prevention, screening, and health promotion. And so some of these things, I'm going to go into, I'm going to talk about each one of these in turn in the following slides, but routine screening for cervical, colorectal, breast, and lung cancer, if high risk for lung cancer, other screening maneuvers, vaccinations, smoking cessation, diet and exercise, and sun sense. And so those are all things that are really important. And so for cancer screening, so we do have some cancer screening programs in Ontario. You should be doing these regardless where age appropriate, and we're eligible and age appropriate. So for colorectal cancer screening, that is for people 50 to 74 years of age. People who do not have a family history of a first degree relative, so mother, father, son, daughter, or brother or sister who's had colon or rectal cancer, should get a stool, or has had an inflammatory bowel disease such as Crohn's or ulcerative colitis, or has a high risk benign condition. So if you have any of those, then you should be getting a colonoscopy. Those are people who are considered at increased risk. But if you don't have any of those things that I've just listed out in terms of your family history of colon or rectal cancer, the test right now in Ontario and pretty much across Canada, except for, I think, one province, but I think they're all on board now, is fecal immunochemical testing. And that's a stool test that you do at home and send in. And again, that's for people 50 to 74. And from 74 to 84, that's something you could still discuss with your doctor in terms of colorectal cancer screening. For breast cancer screening, this is again 50 to 74. It's a discussion between 40 and 50 and a discussion after the age of 74, and that's with a mammogram. Cervical cancer screening is 25, females 25 to 69 years of age, and that's a pap smear every 3 years. And for lung cancer screening, this is just announced, it was just announced in the last week across Ontario, that there is a lung screening program for people at high risk for developing lung cancer. And so these These are people who are age 55 to 74 who have at least a 20-pack year history or 20 years of smoking cigarettes in their lifetime. They can not be current smokers, but they can also have quit smoking. And this is with a low dose CT scan, and you can talk to your providers about having that done if you fit that bill. If you've already had cancer, you don't qualify for that program. Lung cancer, that is. Other screening things, getting your blood pressure checked, getting your cholesterol checked and your diabetes checked, especially if your radiation or chemotherapy involved, putting you at higher risk for heart disease. A bone mineral density, as we mentioned about osteoporosis, and eye examination. The bone density would vary depending upon what treatments you received and how old you are and what have you, but that's something you should discuss with your primary care provider. And then the eye exam, as I mentioned, for early cataracts, if your regimen involved long-term use of steroids. Vaccination. So everyone should get a flu vaccine. If you've had cancer, you should be getting flu vaccines. And in fact, 10 to 15 years ago, we used to put people who had cancer at the front of the line for getting flu vaccinations when we weren't vaccinating the entire population. Tetanus, diphtheria, your tetanus shot every 10 years. And once in your lifetime, you should be getting a pertussis booster that's combined in with your tetanus shot. It's called Adacel or Boosterix. And that is for whooping cough is what pertussis is. And so you should be getting that boosted once in your adult life. Hepatitis would be good to have as vaccinations. It's always worth it to have a hepatitis prevention vaccination. Shingles shot, so some of you might have gotten the Zostavax shot a few years ago. Your immunity wears off after 4 to 5 years of having had the Zostavax. The shingles vaccine is recommended for those people over the age of 50. And if you're between the ages of 65 and 70, the government actually, as of last October, pays for it on your behalf, and that's about $300 out of pocket. So if you're in that age group, I highly recommend that you do get the shingles vaccine. And of course, we are recommending that all cancer patients get the COVID-19 vaccine. And in fact, those who are undergoing active treatment are being brought to the front of the line to receive their COVID-19 vaccinations. We do know that if you're during active treatment or you've had a bone marrow transplant in the past, that you may not mount as good of a response to the vaccine, but you still will mount some response. And those people who have had bone marrow transplants in the past should be getting their vaccine, their second COVID-19 vaccine within the time that's recommended. So whether it be that 3 weeks for Pfizer or 4 weeks for Moderna, should be getting it in that time period, as opposed to waiting the 4 months that we're seeing for the regular population. If you smoke, this would be a good time to stop. It's always a good time to quit smoking. Doesn't matter where you are in the cancer journey. There are many resources you can see. If you're in Ontario, that telehealth, there's the Ontario Smoking Cessation Program that your doctor can refer you to. Otherwise, across Canada, there are many resources put out there by the Canadian Cancer Society, as well as the Health Canada and the Lung Association. Again, I'm going to plug Mike Evans' videos. He's got a really great one on what's the best thing you can do to quit smoking. He's got a great clip on that. And your local public health units, and if you're in Ontario, your hospitals that have cancer centers all have smoking cessation programs. And so you can also access them that way as well. I'm going to move on to nutrition and cancer. I'm just going to look at the time. Okay, we still got some good time. So nutrition is really important, obviously, during treatment, but also after treatment. So immediately after treatment, usually nutrition, we're dealing with some of the repercussions from being treated. So some weight loss or also weight gain. So some treatments cause patients to gain weight. So weight loss can go either way, either that you need to lose weight or you need to gain weight because you've lost a lot of weight. Some people will continue to have gastrointestinal related problems immediately after and for long-term, especially if you've been treated for a GI malignancy, a gastrointestinal malignancy, but also some of the other treatments may cause some people to have issues with constipation or with loose stools and diarrhea. Of course, there's that loss of appetite as well. And for some for some patients, they may have a compromise in their nutritional status. For example, some of their treatments may have caused them to have some iron deficiency. And so these are some of the things that we may need to deal with afterwards. And this is something, again, that your primary care provider can help you with. In terms of the long-term goals, we really want to make sure that your nutrition will promote overall health and quality of life. It will help with avoiding or managing other chronic diseases, so things like diabetes and heart disease. So the same things we would recommend for averting or diabetes or a healthy heart diet are the same things we would recommend for patients who've had a history of cancer as well, just because they are at risk for these chronic diseases and depending on the treatments that they had. And so managing them, you'll manage all three of these things, which are really important in terms of your health status. We know that nutrition can help decrease the risk of recurrence. We also know that it can decrease the risk of developing other cancers. And so what we usually recommend is that we eat a well-balanced meal, a quarter of lean protein, a quarter of your plate should be lean protein, a quarter of your plate should be high fiber carbohydrates, so things like quinoa and barley, and half of your plate should be vegetables. We usually recommend that people limit the consumption of red meat, so things like beef and lamb, and avoid processed meats like cold cuts and canned meats, just because they do have some chemicals in them that may actually be in large quantities, may actually promote cancer or promote recurrence of cancer. So we do want you to minimize those if you can. Limit the consumption of fast foods and other processed foods that are high in fat, starches, and sugars. Also, in terms of what you drink, so we talked about what you eat, and this is about what you drink. So water is great. Just drink water. Tap water is fine. Just drink tap water or unsweetened drinks. That's what we strongly recommend. Limit the consumption of sugared sweetened drinks, and that is regardless of how the sugar comes or how it's sweetened. So even some of the things that might say, 0 sugar or 0% sugar, even some of those things that are put in those drinks to make them sweet, we don't know a lot about them. We do know that sometimes in high quantities, they can be linked to, risks of recurrence and risks of cancer. So often say, again, the safest thing you can do is drink water. And we also say to limit alcohol consumption. And I hate to say this, but it's best not to drink, just because we do know that alcohol is associated with risk of many cancers and also the risk of recurrence of cancers. And so we usually recommend limiting alcohol consumption. But if you are going to drink, we recommend that no more than 9 drinks for women and no more than 14 drinks per week for men. And 9 drinks is either 1.5 ounces of hard liquor or 1 standard size beer or 1 5 to 6 ounce glass of wine. So although we say drinks, it's not a bottomless cup or a bottomless drink of consumption. So the other thing that always comes up that we get asked about is there a specific vitamin or supplement or herb or spice that we should be consuming? So I've seen every fad in terms of preventing cancer and in terms of preventing risk of recurrence of cancer. So we've heard about turmeric and curcumin and oregano and parsley and garlic and cinnamon. And so none of these things have actually been proven. None of them have been shown to be harmful. So if you enjoy those spices and you enjoy consuming them, feel free to go ahead. Same with vitamins. But there actually is no evidence to support that any of these things will avert your cancer from coming back or prevent you from getting cancer. They are being studied. They continue to be studied, and there's studies that come out all the time about them. Oftentimes we don't see them come out because a lot of these studies don't get published because they don't show to be beneficial. But that's not to say that in 20 years we're going to find out that oregano is this spice that does prevent recurrence. I'm making that up. Obviously, I don't know anything about oregano, but we do know that right now to date, there is no evidence to support that. People always ask about vitamin supplements. Should they take a multivitamin? Should they take vitamin A, B, C, D, E, F, G, right to Z? Again, there has been still to date no vitamin supplement that has been shown to prevent the recurrence of cancer or to prevent the onset of cancer. If you eat a healthy diet and you eat lots, a well-balanced diet with lots of fresh, home-cooked and non-processed foods, you will get all the vitamins that you need. So right now there is actually no recommendation for any vitamin. Vitamin D is probably the only one that sits on the fence because you really can't get that from diet. You can get that from the sun, and that we do fortify milk with vitamin D. But other than that, if you ate a well-balanced diet that is full of vegetables, fruits, whole grains, and legumes, you will get all the vitamins that you need. Mediterranean diet's a good one to follow. And as you can see, if you look at this pyramid, the stuff on the bottom is the stuff that you should have lots of and do lots of and consume lots of. So physical activities at the bottom, you can see lots of fun stuff there in terms of dancing, in terms of going for walks or playing a sport. Things that we should consume a lot of are those fruits and vegetables and grains, mostly the whole grains, olive oil, beans, nuts, legumes, seeds, herbs, and spices. You can see that we recommend that you consume them. Fish and seafood would be the next. Then poultry, eggs, cheese, and yogurt. And you can see at the very top, that's not to say that that's what you consume a lot of. That's very rarely is to consume meats and sweets. And on the side there, again, alcohol is at the top there in terms of rarely consume it versus water, which should be consumed as your main thing that you drink. So by following these recommendations, you'll reduce your intake of salt, you'll reduce your saturated and trans fats, you'll help prevent other chronic diseases such as heart disease and type 2 diabetes. And I just want you to know that type 2 diabetes has been associated with some types of cancer. So this is the one that you really want to try and avert and avoid by eating well and eating a well-balanced, healthy diet. Exercise, I can't say enough good things about exercise. Trying to exercise will help with trying to maintain a healthy weight. Exercise helps with energy, it helps with sleep, it helps reduce cardiovascular risk factors such as high blood pressure, diabetes, and weight. And it also has been shown to help with mood, so depression and anxiety. So can't say enough good things about doing exercise. And as I mentioned earlier, getting at least 150 minutes per week, so good 30 minutes per day, 5 days per week at least. And there is a guideline that you can discuss with your primary care practitioner. It's a physical activity guideline. It came out from Health Canada. And as I mentioned, aim for a minimum of 30 minutes per day, 150 minutes per week. Focus on cardio training, but also incorporate some strength training in there at least twice per week. Be sure to stretch daily and try to find ways you can increase your physical activity. So take the stairs instead of the elevator, walk instead of taking your car, dance if you can, and put on some music and dance at home. It's all good for you in terms of maintaining your good health. And then I did forget to put in a slide about SunSense. Really important that you use sun protection. There are many cancers and some chemotherapy treatments and some radiation treatments that do put you at risk for skin cancer. So I do highly recommend as well, and I forgot to put a slide in here about that, about SunSense and making sure that you use proper SPF protection for your skin because of that increased risk. And just want to say thank you and stay well during COVID. I know this has been tough for many of you who are really trying to hunker down at home because of your cancer history and because of being worried about getting COVID. So I do want to thank you for also staying well and hunkering down and staying home to try and avoid getting cancer. And